Hello, and welcome to the 6th webinar of the Ariadne Labs Implementing Checklist for Quality Improvement webinar series. My name is Emily Benatti, and I just wanted to welcome you and thank you for joining us today. While we're waiting for everyone to join, I just want to run through some WebEx information with everyone. So we'll be keeping the phone lines on mute to cut down on background noise. And if you have a question or comment at any point during the webinar, you can either type it into the chat box that you'll see on the right-hand side of your screen, or use the raise hand icon, and we might be able to call on you so you can ask your question out loud. And that might come in handy, especially during the Q&A portion at the end of our webinar. Also, if you have at any point any technical questions or concerns, again, please use the chat to host function and I'll assist you directly. So we're very excited to have you all joining with us today, and we'll be starting the webinar shortly. Hello again, and welcome to our 6th webinar of the Ariadne Labs Implementing Checklist for Quality Improvement webinar series. My name is Emily, and I will be facilitating the WebEx session today. If at any point you have any questions or comments during the webinar, you can either type it into the chat box on the right-hand side of your screen or use the raise hand icon, and we will call on you so you can ask your question out loud. And again, that might come in handy, especially during the Q&A portion at the end of our webinar. And it's also important to note that depending on your computer type, your screen might look slightly different than what is shown here, but you should have the same functionalities as what I've just described. So again, if you have at any point any technical questions or concerns, please be sure to use the chat to host function and we'll assist you directly. I'll now hand it over to Dr. Catherine Semrau, who will be moderating today's webinar.
Hello and welcome. My name is Catherine Semrau and I'm the Director of the Better Birth Program at Ariadne Labs here in Boston. I'm delighted to welcome today's panelists who will discuss respectful maternal care and their experience with incorporating RMC into their quality improvement projects. Today, we are joined by Rima Jolivet, Dr. Rose Molina, Dr. Saraswati Vedam, and Mr. David Sando. As you can see here, I'd also like to thank everyone who's completed this poll and joined us here today, where we're joined by a range of public health professionals, researchers, and clinicians. In order to achieve the agenda and the goals that we have listed here today, for today's webinar, we're going to look at the background of both organizations, Ariadne Labs and the Maternal Health Task Force, review this webinar series to date, focused on the WHO Safe Childbirth Checklist and using it as a quality improvement tool, defining what is respectful maternity care, and using a series of case studies from Mexico and other locations around the world in Tanzania, and we'll summarize through a series of key takeaways and next steps. The goals of this webinar today are really to learn the basic principles and issues related to that respectful maternity care, understand how RMC relates to quality of care, and hear from global implementers about their strategies about integrating respectful maternity care into quality improvement initiatives. Just to highlight the two organizations that are presenting here today, as well as the other implementers that will be sharing their stories, I'd like to note that Ariadne Labs is a joint center between Brigham and Women's Hospital and the Harvard Chan School of Public Health. We have experience implementing checklists for quality improvement, such as the Safe Surgery Checklist, the Safe Childbirth Checklist, and the Serious Illness Conversation Guide. Through these tools, along with other projects, our mission is to build and support a community of researchers and practitioners who create and drive scalable solutions that produce better care at the most critical moments in patients' lives everywhere. During this webinar series, we have drawn on the experiences across our program to share lessons learned in implementation, adaptation, and coaching. As mentioned today, we are happy to be joined by members of the Maternal Health Task Force. The Maternal Health Task Force, a project of the Women and Health Initiative at the Harvard T.H. School of Public Health, works to create a strong, well-informed, and integrated community of individuals around the globe focused on ending preventable maternal mortality and morbidity worldwide. The Maternal Health Task Force seeks to advance high-quality maternal health care by providing practitioners, policymakers, researchers, and advocates access to the most current and reliable information, evidence, and resources through an open access knowledge management system. The Maternal Health Task Force also trains and mentors the next generation of maternal health leaders and generates new evidence for program development and policy advocacy through targeted research addressing emerging or neglected areas within maternal health. Throughout this webinar series, we've presented the different stages of the implementation pathway and heard from global partners about how they approached each phase along the way. We first introduced the WHO Safe Childbirth Checklist, then discussed how to engage with stakeholders and facility team members to gain buy-in, create an implementation team, conduct a needs assessment, and how to adapt and own the checklist. In the third webinar, we heard from implementers in Mexico and Indonesia about their experiencing launching the checklist in their facility. And after that, we presented coaching as a critical component to successful checklist implementation. We discussed what coaching is and is not, how to give feedback, then had an interactive practice session. And finally, in this previous webinar, we learned about the monitoring and evaluation methods and how to set and measure metrics for checklist implementation. We heard about the different ways in which this was done in India and Namibia. Now this brings us to where we are today. Today, we're focusing on the last portion of the implementation pathway, where the goal is a strengthened system and improved quality of care. Now, high quality of care has been defined in many ways, but one aspect is the adherence to the basic essential birth practices and providing the best care for women and newborns around the world. Implementers have discussed the facilitators and barriers on how the checklist may have impacted quality and care in their facilities. Today, we're going to dive in even further into quality of care in maternal and neonatal health, and in particular, respectful maternity care. I am now delighted to introduce Rima Jolivet, the Maternal Health Technical Advisor of the Maternal Health Task Force at the Harvard Chan School of Public Health. Rima?
Hi, Catherine. Thank you so much for this introduction, for inviting me to participate in the webinar. I'm going to give a brief overview of respectful maternity care. Next slide. I'm going to start with a brief background, a little bit of history. I wanted to call attention to two different movements that came up independently of each other. The earlier one originated in Latin America against obstetric violence, grew out of the women's movement, and focused very much on autonomy and self-determination, and on women's ability to make choices about their reproductive health and their bodies in the context of childbirth, including position for giving birth, eating and drinking during labor, choice about refusing over-medicalization, choosing who's in the room, etc. And the counterpart, or the response to that, was humanized birth, and humanization of birth was defined first in 2000 in an international conference, and was defined as a process of communication and caring between people leading to self-transformation. So again, this idea of self-determination and empowerment of women. At the same time, so this was largely influential and continues to this day. And somewhat in parallel, in 2010, so at a later time, there was a movement that began, I would say, probably triggered by a commission by the U.S. Agency for International Development of a landscape analysis by Bowser and Hill that was triggered or spurred by many anecdotal reports that were emerging of disturbing experiences that women were having in the context of facility childbirth. And so that landscape analysis was commissioned and was highly influential, and USAID at the same time commissioned the White Ribbon Alliance to lead an advocacy effort, including convening a community of concern who worked together to develop the Respectful Maternity Care Charter, the Universal Rights of Childbearing Women. They also commissioned some research that was designed to look at the prevalence of these categories of disrespect and abuse, and to examine drivers, and to develop and test targeted interventions based on those findings. So all this work was quite influential, and in 2014, the World Health Organization issued a statement on disrespect and abuse of women during childbirth that called for concerted action and research, and also named respectful care as an essential component of quality. And this was the first time that this was done, and was very significant. Also, finally, in 2015, the World Health Organization published an updated systematic review of the healthcare literature. The Bowser and Hill analysis threw a very wide net and looked at laws and policies, and gray and white literature, and interviews as well. The updated WHO systematic review focuses on the published health literature and proposes slightly new and different typology for mistreatment of women during childbirth. Okay, next slide. So these are these two frameworks. The one on the left, Bowser and Hill, has been most used, I would say, most often for research to try to measure the prevalence to date, although there is quite a bit of research going on currently, led by WHO, using the typology on the right. And you can see that they're highly complementary and somewhat different. Why is disrespect and abuse of women during childbirth important? Obviously, it's important fundamentally as a human rights issue and an ethical issue, but also Concretely, in terms of implications for maternal health outcomes, women who experience disrespect and abuse during childbirth are less likely to deliver in a facility in the subsequent pregnancy or to seek facility-based care in the future, and that includes the influence of their experiences during antenatal care, their previous birth experiences, any stigma or discrimination, or even their perceptions about the quality of care at a facility. Next slide, please. Another study that's recently by Larson and colleagues came out in 2015, presented 3,000 women in Tanzania with a discrete choice experiment, giving them profiles of facilities with different attributes and asking them how they would value those attributes in making a choice. And what it showed was that the greatest predictor of preference for one facility over another was kind treatment by a doctor, followed by medical knowledge by the doctor and by the availability of equipment and drugs. But the #1 predictor was kindness. So it is important for a variety of reasons. I'd like to just make the point that the absence of disrespect and abuse is not the same thing as respectful maternity care. As important as it is, it would be possible to refrain from disrespect or abusive treatment and still not be particularly kind or respectful. And so I'm going to pivot a little bit to talk about how we understand respectful maternity care and just propose a couple of different lenses. One lens is a human rights lens. I referred previously to this charter that was developed by the White Ribbon Alliance, and it was based on those 7 categories of disrespect and abuse from the Bowser and Hill framework, and then a search through human rights declarations and conventions to identify the corresponding rights to those, to counteract the entitlements to counteract those forms of disrespect and abuse. And I'd just like to point out that there are other rights-based frameworks. There are numerous national laws against obstetric violence in Latin American countries. Rajat Khosla and colleagues published in the Journal of Health and Human Rights an article looking at international human rights and the mistreatment of women during childbirth. And the Office of the High Commissioner of Human Rights has emitted in 2012 technical guidance on the application of a human rights-based approach to the implementation of policies and programs to reduce preventable maternal morbidity and mortality. So those are just a few other rights-based frameworks. However, another lens, next slide please, is to think about respectful maternity care through the lens of quality, clinical quality of care. And in 2015, the World Health Organization issued a framework for quality of care that elevated the experiences of care alongside provision of care as equally valuable, equally important components of quality of care. And you can see that under experiences of care, effective communication, respect and preservation of dignity and emotional support are included as key components of positive experiences of care under the concept of quality. Next slide, please. Just drilling down a little bit further into this, you can see that each of these 8 standards for quality has quality statements attached to them. So just for example, under Standard 5, that women and newborns receive care with respect and can maintain their dignity, one of the quality statements is that all women and newborns have privacy around the time of labor and childbirth and their confidentiality is respected. Also, another statement, no woman or newborn is subjected to mistreatment such as physical, sexual, verbal, abuse, discrimination, neglect, detainment, extortion, or denial of services. So these are drawn directly from those definitional frameworks or typologies. Okay, next slide, please. Finally, I just want to point out that there are some challenges with how we define and understand disrespect and abuse and respectful maternity care and how we operationalize those definitions and for what purposes. So, you know, these have been extremely helpful, these frameworks, to help us categorize, classify, and understand these phenomena, but their use to measure prospective literature design programs is complicated because whose perspective is being captured? Is it possible to create a valid, standardized definitional framework that would work across all settings to capture people's human and subjective experiences? How would you operationalize a construct like non-dignified care, and would that be the same in every place? So I just bring these to the forefront, and I think people will be describing and talking about this a little bit more in this webinar series. Next slide. it's important for us to understand the drivers, and that's one of the reasons why we're trying to create these frameworks for defining and measuring these phenomena. But the evidence certainly suggests that disrespect and abuse during facility-based childbirth is a very widespread phenomenon with different manifestations, varying degrees of severity, and different drivers across settings. And those drivers could be at the provider level, they could be health system driven, they could be driven by laws and policies, or underlying structural inequalities and gender inequality, social and cultural norms, et cetera. And each of these drivers probably requires a different approach to intervention. I want to call your attention to a recent paper by Warren and colleagues in BMC Pregnancy and Childbirth in 2017 called Manifestations and Drivers of Mistreatment of Women During Childbirth in Kenya, Implications for Measurement and Developing Interventions. And it goes through these issues very well and in a particular context. So that would be of interest. Finally, my last slide. So my key takeaways in summary are that disrespect and abuse of women during facility childbirth has different manifestations and different drivers. The basic constructs and the frameworks that have been developed through review of the available evidence may be generalizable and are very helpful, but their operationalization may need to be context-specific, particularly to make sure that what is being measured or what is being intervened is valid in the local context. And again, absence of disrespect and abuse is not the same thing as respectful maternity care. We don't have that much evidence or agreement about what constitutes respectful maternity care, although there are people who are working in this domain, and you'll hear from some of them. What's perceived as respectful is subjective and may vary across settings, and so that women's voices are very important. Women-centered participatory research is really needed to explore this concept so we can understand how women define RMC before implementing it, whatever it is. So with that, I'd like to say thank you and pass it on.
Thank you, Rima, so much for your insights into the respectful maternal care definition and frameworks and the history around it. Next, I'd like to introduce Dr. Rose Molina, an obstetrician gynecologist at Beth Israel Deaconess Medical Center, who's been partnering with Ariadne Labs and Partners in Health, looking at implementation of an adapted safe childbirth checklist in rural Chiapas, Mexico. Rose?
Thanks, everyone, for the opportunity to present about how we integrated respectful maternity care into our version of the checklist in Mexico. So just a brief background about our organization. I work with Partners in Health in the southernmost state of Chiapas, which borders with Guatemala and is one of the most marginalized regions with greater than 75% of the population living in poverty and suffering among the worst health outcomes in the country. With funding from the MacArthur Foundation and in collaboration with Ariadne Labs, we built a maternal health team to improve the quality of care during childbirth while strengthening the roles of professional midwives and obstetric nurses in a health system that traditionally favored physician attendance at all deliveries. In this project, we are partnering with the Ministry of Health to rebuild trust with communities through our bridge between the health facility and rural communities. Additionally, we seek to understand how our intervention works through the eyes of the women we care for in both of these areas. We developed a comprehensive approach to improve maternal and newborn outcomes through optimizing quality of care at the facility level and addressing barriers to accessing care at the community level. Our facility-based intervention was designed using the WHO framework of conceptualizing quality as both provision of care and the experience of care, which Rima referred to earlier in this webinar. Our comprehensive facility-based intervention addresses the value chain of care around childbirth. At our foundation is a multidisciplinary team of clinicians, program managers, researchers, data collectors, trainees, and volunteers. We provide training around an adapted safe childbirth checklist, which is supplemented by a monthly hands-on clinical training curriculum. We seek to create a culture of respect and dignity for women who come to deliver at the hospital and have integrated some of these practices into our checklist. We provide transportation for women from rural communities to the hospital and food and lodging for women in early labor along with their birth companions. Lastly, we support the supply chain for prenatal, intrapartum, and postpartum services in the hospital and in the community clinics. In Mexico, the National Institute of Public Health has already adapted the checklist and is implementing it in several hospitals in the state of Mexico. In Chiapas, we further adapted the Mexican version to include elements of respectful care, which we thought were critical to achieving high quality and regaining trust in the health system. We added items throughout the 4 checkpoints to emphasize the importance of communication and woman-centered care. Some examples include allowing women to choose their position during delivery, given we have no anesthesia providers and limited options for pain relief during labor and delivery. Another important aspect of respectful maternity care that we integrated is offering birth companions to be present throughout labor and delivery. As you can imagine, women reported that delivering in a facility without their partner or family was a lonely and scary experience. One other example is ensuring appropriate and respectful communication between health professionals and women about the process and plan of care throughout their stay in the hospital. We added this because many women reported that they did not understand what happened during their delivery because it was never explained to them. For example, we found that many women were unsure whether they required an episiotomy or whether they had a laceration during delivery. This is an important distinction as we work to reduce the number of non-indicated episiotomies and alleviate the fear women have of requiring an episiotomy after their first delivery. We designed a mixed method study to evaluate the implementation of our facility-based intervention. With regard to evaluating respectful maternity care, we explored perceptions of care with follow-up interviews with postpartum women 2 to 4 weeks after their deliveries. We are in the middle of analyzing our qualitative interviews, but some themes that have surfaced center around how women perceive good versus bad care. We found that there can sometimes be a tension or simply a difference in how women conceptualize high-quality care and how health professionals think high-quality care should be defined and delivered. Women identified examples of good care in ways that really embodied communication, kindness, and trust, such as feeling supported during labor, being cleaned after their delivery, whether they were checked in on after their delivery, and whether they were provided material support, such as food or diapers, during their hospital stay. One salient example of bad care that was described multiple times centered on the word regañar, which means to scold, chastise, or yell at, particularly with regard to withstanding labor pains while in the hospital. Sometimes there's a misalignment in these worldviews, such as the idea that some women really view immediate skin-to-skin as bad care because it is an indication that the nurses don't have the time, the supplies, or the interest in cleaning the baby before presenting the baby to the mom. Whereas health professionals all tend to think this is an evidence-based practice that should always be done. We hope to use these lessons learned to continuously improve how we deliver the timely, evidence-based care in a respectful and woman-centered manner.
Excellent. Thank you so much, Rose, for sharing your experience in Chiapas, Mexico. Next, I'd like to introduce Dr. Saraswati Vedam, who's the principal investigator at Birthplace Lab, as well as the Associate Professor at the University of British Columbia in the Division of Midwifery. Dr. Vedam, over to you.
Thank you, Catherine, and greetings to everyone joining us today. Today I'm going to talk to you a little bit about what women think is important regarding respectful care and how they define quality and safety. To do that, I'm going to tell you about some studies that we did that led to the development of new measures of respectful maternity care that were patient-designed, and how that helped us understand the drivers of the disparities in experience across populations and helped us to inform some effective change strategies. When you're trying to figure out what the real drivers are and what the characteristics of respectful maternity care, or any study question, you have to ask the right questions in the right way to the right people and ask enough people. One really effective way to do that is through participatory research. In participatory research, all the stakeholders the people who we're studying, or the phenomena we're studying, is informed by the stakeholders. So they are involved in designing the study, figuring out what questions to ask, who to ask them to, what the outcomes that we should measure are, how you collect the data, and then they're fully involved in the interpretation, dissemination of results, and implementation. Two of those studies that we did in North America were Changing Childbirth in BC and Giving Voice to Mothers. Changing Childbirth in BC was a provincial study. Giving Voice to Mothers was a national study. Changing Childbirth in BC had childbearing women who reported on up to 3 pregnancies and up to 3 different types of providers that they had. We had formerly incarcerated women, women who were experiencing multiple challenges living on the street, immigrant and refugee women, as well as women who were experiencing no barriers but were pregnant or had recently had a baby. In giving voice to mothers, we worked with communities of color and women who chose to deliver in homes and birth centers to understand if their experiences were different from others. They were provincially and nationally funded, and our transdisciplinary teams included NGO leaders, community leaders, researchers, but most importantly, the teams and steering committees were led by and initiated by childbearing women in BC and the U.S. They decided that they wanted to study access to care, preferences for model of care, experiences of maternity care, especially informed decision-making, respect, autonomy, and racism. These were the topics that came organically from our consultations and from their initial meetings. Today, I'm just going to talk to you about the respect, autonomy, and decision-making items that they designed, a little bit about racism. So they decided they wanted to do surveys and focus groups, but that the existing surveys that we brought to them were not exactly asking the questions in the way they felt it was important or capturing the information. So they adapted previously validated survey items, drafted new questions, and then they rated each question for relevance, clarity, and importance to their own communities. And then, of course, they have been involved all the way through to implementation. They also said it was important to translate every item into other languages, in this case Spanish in the U.S., and that the images that we use for recruitment should be pan-ethnic and not assume that the pregnancy went to term. So they chose the images also. When they talked about non-consented care, they said it was not important. It was as important to ask what they declined, but also why did they decline it? That whether or not they felt that it wasn't necessary or someone was rude when they asked them. And then also they felt that it was important to ask how the doctor, midwife, or nurse reacted. They did the procedure against my will, they alerted Child Protective Services, or they accepted my decision. Did someone help you to try and keep your wishes in the discussion? They felt it was also important to see who were their advocates and how that turned out. With respect to decision-making, the process of the development of the instrument led to the development of actually a quality measure. We validated and did the psychometrics to develop a scale where we had a quantitative measure of autonomy, where the total score was 7 to 42, and showed how much autonomy or respect they had. And with respect, they said that it was important to ask not just whether or not they were comfortable asking questions, but whether or not they felt pushed into accepting options and whether or not that affected their behavior. In other words, did they hold back their questions because of how they felt they were being treated? I'm going to tell you a little bit about the results now. Women said that 95% of women said that it was very important or important to them that they lead the decision, and that maybe about 20% of them said that it was important that their doctor midwife guided the decision or had input, but at least half of women said that it was not so important, that they wanted to be in the driver's seat. However, when we asked them what really happened, for example, with cesarean, we asked them who made the decision to have a C-section, and in this case, they said their maternity care provider recommended the C-section either before they went into labor or when they were in labor, so they were not able to be in control of those decisions. Similarly, with autonomy, with their sense of autonomy measured by the Madam scale, we found there were large differences across populations. You can see here that big differences for Black women, white women, and Latina women, and those were especially affected if they had low resources. Similarly, for respect, low resources and race mattered, and less respect with women of color and who had less resources. when they asked us to separate their answers by provider type, and that allowed us then to show where these autonomy and respect experiences were being driven. Here it shows that there were higher autonomy scores for midwives and lowest for obstetricians. And the same was true for respect, although there were less significant differences there. Place of birth mattered. Certainly if they were at planned home birth, when they actually delivered, they had higher autonomy and respect scores, and the least if they were in hospital. The highest scores, this doesn't mean that they have less autonomy than respect. The total score is just less. When we asked them about abuse and when they designed the study, the questions around abuse and disrespect, they actually described what it looked like. Healthcare providers ignored you, refused your request for help, or failed to respond for requests in a reasonable amount of time. 20% of women said that that was true, and if they were of color, it was much more present. Similarly, place of birth mattered, whether or not they felt threatened, whether they were shouted or scolded, and if they transferred to a hospital after their labor started, their respect and autonomy scores were much, much lower. When we asked, there were assumptions made about the stressors for women being around violence in their neighborhood or access to health services, we actually found that the biggest thing that they added and that no one had thought to ask before was violence against their family and family members. That actually for Black women in particular was a major area of concern. So when we interpreted this and talked to the community, they told us that women held back their questions if they wanted different care because they were worried about poor treatment, that they needed time to process information, and that if they did have that, they had greater autonomy. That while 30% in North America felt pressure to have a C-section, that led to C-section sometimes, but even if they didn't have a C-section, if they refused it, if they had pressure, they felt less autonomy and less respect. So poor treatment was reported regardless of provider type and led to reduced respect and autonomy. We know from other research that 84% of these differences in attitudes can be explained by care provider alone. When you ask providers, they'll say that exposure and education lead to favorable attitudes towards birth and options for care, and in North America, financial factors and liability lead to unfavorable attitudes. So what we can understand from this research that was informed by the women is that fear of neglect, fear of being alone or abandoned, fear of the unknown, fear of trauma, all of those things actually lead to failure to seek or accept care. One woman said, one doctor in particular was awful. He bullied me, tried scare tactics, ganged up on me by showing up with a team of 4 to convince me to do what he wanted. It made my labor unnecessarily stressful. I will avoid the hospital at all costs and any future pregnancy unless absolutely necessary. So what can we do? We decided that what we needed to do was expand respectful communication and shared decision-making curricula and help women to understand their human rights. We've developed a course to teach all types of professionals around shared decision-making, and we've developed best practice guidelines around what happens when they transfer into home from hospital, and these are informed by this participatory research. You can access those tools at this website, and they are free and open source. Thank you.
Thank you very much for the insights from the United States and Canada, Dr. Vadam. Having heard from the Americas, now let's turn our attention to Tanzania, and Mr. David Sando will be presenting on improving quality of maternal health services in Tanzania. He's a PhD student in global health and population at the Harvard T.H. Chan School of Public Health in the Management and Development for Health program. David?
Thank you for inviting me to participate in this webinar on integrating RMC in cure initiatives. My name is David Sando. I'm a PhD student from Harvard School of Public Health, and my talk is going to discuss on improving quality of maternal health services in Tanzania. As it has been discussed by the previous speakers, mistreatment of women during childbirth is recognized as a significant obstacle to quality maternal health services and outcomes around the world. In Tanzania, numerous studies have shown that disrespect and abuse is a major contributor of low fertility delivery and poor pregnancy outcome. Based on these qualitative and quantitative findings and studies, we designed a study that intended to assess the types and prevalence of disrespect during childbirth, but also identify different factors associated with disrespect and abuse, and use this to design and implement an intervention that will reduce the occurrence of these behaviors. We conducted a baseline survey in which we carried out exit interview of women post-delivery. We also sampled women for community follow-up, conducted observation of labor and delivery process, and also interviewed providers. In all of this, we found high rates of occurrence of this disrespect and abuse. 15% reported occurrence of disrespect and abuse during exit interview, while in community follow-up, 77% of women reported to experience at least one of these. And with the provider, we also found out that there was a low knowledge of clients' rights and also high dissatisfaction with their jobs and interaction with their clients. Using these findings, then we conducted multi-step dissemination, where we started at the facility level and then went to the district and then used the feedback and information we received during facility and district level dissemination to prepare and conduct a nationwide dissemination meeting. And the information that we collected, we were lucky to receive extensive ideas and feedback from all these disseminations meetings and use that to characterize the problem, and selected a technical working group that was tasked to use all the information and findings that we have received from the disseminations to select a few interventions that are feasible and sustainable and cost-effective in the setting that we were working. And the team came up with two interventions, which was RMC workshop and also open birth days. And the open birth days was actually designed to improve pregnant women understanding of their rights and expectation during labor and delivery, where they were given tour and also education sessions, while for the RMC was intended to actually improve providers' knowledge and understanding of clients' rights, ethics, and also values. We had several mechanisms to monitor the process and impact of these interventions, but also we conducted end-line evaluation by doing direct observation of labor and delivery. We had community follow-up interviews and healthcare providers interviews. The table in the result session actually shows different dimensions of disrespect and abuse that we monitored and evaluated in this intervention, in this evaluation. The first two columns indicates the baseline, shows the baseline, exit interviews, and community follow-up, while the last three shows the community follow-up findings overall, and then disaggregated by being exposed and not exposed to open birth days. Overall, the finding shows a decline in disrespect and abuse post the intervention as compared to the baseline findings. And when you look at those who were exposed as compared to those who were not exposed to open birth days, we see also there was a big difference indicating that open birth days were likely to, or there is some potential that open birth days was actually related also to decreasing the prevalence of this disrespect and abuse. When you look at the findings we obtained from the observation, we had several elements that were selected for observation, and in all of these elements we see a huge decline after the intervention, and with, I think, it's only no pad provided to the mother that actually we see that there was a huge increase, and this is because this was not modifiable at a facility level, but all other elements which were modifiable either at a provider level or facility level, we see that there was a huge decline. And these changes actually most occurred because either there was an increased knowledge, improved attitudes, or increased communication between clients and providers. So in summary, the observed and reported disrespect and abuse has decreased substantially from when we did the baseline survey to the endline survey. The process of naming the problems, stating the dialogue, engaging stakeholders around potential solution was critical to this success. Even in constrained health system, results show that changing attitudes and behavior can affect significant change, but all disrespect and abuse cannot be addressed without structural and systemic changes. Results from this pilot was very encouraging, but it shows that more work needs to be done, and that combined with increased dialogue, open birthdays, and RMC workshop have shown promising results. Thank you very much for listening, and now it's open for discussion. Thank you.
Excellent. Thank you very much, David, for the experience from Tanzania and starting to think about what interventions may work to reduce disrespect and abuse during childbirth and labor and delivery. So we've heard from our 4 speakers, and we'd like to take a pause now to have participants respond to the poll that you'll see on your screen, and we'll leave this open for 30 seconds. And once you've responded to the poll, be thinking about the questions you'd like to ask to our panelists that we have available to respond to questions, including David Sando, Rose Molina, and other team members as well. So we'll come right back with poll results. Excellent. So you can see here from the poll results that we have in the question of what do you think are the biggest challenges to ensuring respectful maternity care, and we offered several options and people responded the most. The highest reported biggest challenge is the systemic pressures, that maybe there's too many patients and not enough beds, which is leading to higher levels of medical intervention. And also several of you thought that the lack of provider training, as well as the provider burnout, motivation, and cultural norms are also leading challenges that we need to deal with when we think about respectful maternity care. So just to say thanks again to our panels today for this interesting and informative webinar, we're going to move into questions from the audience at this point. Emily, can you describe how to use the chat and raise hand function?
Yes, absolutely. So again, if you have any questions for today's panelists, you can use the chat function, which should be on the right-hand side of your screen. You can also try to use the raise hand function, at which point you would have to unmute your phone and ask the question verbally. However, using the chat function and just typing out the question on the right-hand side is probably the easiest method. So we'll now open it up to questions from the audience.
Great. So Nabiha, you had an initial question?
Yes, hi, thanks for a great webinar. I have a question for Dr. Molina. I was wondering if you could tell us a little bit more or give us some examples on some of the questions or items that you added to the Safe Childbirth Checklist to encourage respectful maternal care.
Sure, absolutely. Thank you for the question. So as I mentioned in my brief presentation, some of the key elements that we wanted to ask about were freedom of birth position during labor and delivery, presence of birth companions, and then respectful communication between health professionals and providers. So some of the specific sort of language around those questions that we've integrated into the checklist was, first, does the patient want a birth companion during labor? And we have options such as yes, and they are present, yes, but they are not present, reason for not being present, no, and then option was not offered. We also asked questions such as, did you discuss the following with the patient regarding labor and delivery? Clothing preference, pain relief strategies, and privacy concerns. Again, with privacy concerns being part of respectful practices in terms of ensuring curtains and discussing how patients' information would be protected throughout their stay in the hospital. And again, another example of another question is whether the patient was allowed a free birth position during her labor and during her delivery. And so some of these questions we integrated throughout the checklist at the different pause points. So some of them were asked multiple times to follow women throughout their labor course.
Great, thank you so much, Rose. So it looks like we have a couple of other quick questions. The first one is, can I use the tools that Saraswati mentioned at my facility?
Yes, so all of Saraswati's tools that she mentioned are available for the public for free to download at the Birthplace Lab, and that information will be uploaded to the Better Birth community after this webinar, so you'll be able to take a look and download those tools for you to use at your facility.
Great. Thank you so much. And we actually have another question from one of our participants. Do you have any experience on birth planning or and it's linked to decreased disrespect and abuse?
This is Rose Molina answering that. For our particular area in Mexico, we don't have a lot of evidence around birth planning and outcomes. However, I think there's a lot of strong evidence in other settings, such as what Saraswati had presented around sort of situations in North America. I think that for us in Mexico, we think that birth planning is an important tool for communication, and again, I think just focusing on that relationship between the health provider and the patient in optimizing the communication as sort of a two-way experience. And birth planning, depending on the setting, could be occurring in prenatal care, which is a much more longitudinal relationship, but where we're focused with the Safe Childbirth Checklist around the admission for childbirth, we really integrate the birth planning as part of the communication process around the plan of care throughout the stay in the hospital, as opposed to the prenatal care planning, which would occur in the health facility, in sort of other health clinics.
Excellent. Thank you, Rose, very much for the response. And Emily, do you want to add one more question from a participant?
Sure. It looks like we have another question here, and it says, I've been working in MNCH in India and Sub-Saharan Africa for 10 years. One piece of the webinar that I missed hearing on is access to bathrooms and showers. Is this something that was featured in Mexico and or Tanzania? And in her experience in Malawi, where she worked for 2 years, it was a major issue. Women had, for example, no access to clean toilets or running water to wash before or after birth, which then led to a stigma and abuse by the provider, as often it was in a poor state. So maybe, Rose, if you'd like to chime in on this. And then David Sando, who we have on the line, we can see if we're able to connect with him.
So I think that's a really important point that the participant brought up with regard to access to sort of basic human dignity facilities like a bathroom and a shower. And so for us in Mexico, we were very lucky in that we have what's called a maternal guest house, which is a separate building that is on the same grounds as our small community hospital. And that is where women end up going during the early phase of labor. So some people might call it a waiting home. We use it for women in early labor or who travel from very remote communities to come in anticipation of their delivery date. And in that maternal guest house, there is room not only for the woman, but also her birth companion, and there is a bathroom and a shower and a kitchen for them to prepare their own food. I think that for us in Mexico, one of the biggest barriers for women to come to a health facility was actually just providing their own food, because the hospital itself did not provide food. And so it was a source of stress for women to travel from remote communities and not have a place to prepare food or a place where they could afford a day's worth of food for both themselves and their birth companion. So I think that's an important point, and the way that we've addressed that in Mexico is to have a separate building, which we sort of treat as a waiting home for women that does have those facilities.
Great. Thanks so much, Rose, for sharing the experience in Mexico. We're going to try and have Mr. David Sando respond from the experience in Tanzania. David, can you talk a little bit about the access to the bathroom or showers availability in the Tanzanian model?
Oh, thank you so much. Can you hear me?
Yes, we can, loud and clear.
Oh, yes. So actually our experience in Tanzania, it sounds to be a bit different from the Mexican one, because there is definitely access to the bathroom in terms of the restroom, but the showers are actually not widely accessible in most of the labor wards. And most women get to be washed up actually in their bed with either nurses, because usually you don't have companions in the labor room. So it's really one of the biggest source. I think one of the major drivers or facilitators of sometimes abuse, because depending on how busy the room is, sometimes you have one provider who needs to provide all the supports, including clinical care, but also some of these kind of care in the labor ward. And then it's hard actually to meet all the demands actually that are there in the labor ward. So the experience is a bit different here, and the access is quite limited in most of the labor wards in Tanzania, especially in public facilities that we're working with, and yeah.
Thanks very much, David. I was wondering, maybe you could speak a little bit about what are the next steps for your program now that you've had this initial experience with using the birthdays and other interventions to keep working in this area?
Yeah, so what we actually did was to kind of try to liaise with the Minister of Health, the policymaker, to see how some of the findings that we gathered from our study could inform policy, but also practice. And when this study was being implemented, the local partner was the MDH Management and Development for Health, the local organization which is responsible to support healthcare provision in some of the districts in the country. And because of their direct involvement in planning and practice and capacity building on the ground, MDH have taken this as part of their package when they train and capacitate people who are working, providers who are working in maternity care, including supporting development of initiatives such as putting curtains for privacy and ensuring actually confidentiality. So there have been a lot that have been done as a result of this study, both in terms of informing the practice, changing actually the approach that MDH has been using in supporting the expansion of this quality maternal health services, but also informing the ministry and trying to also see how we can support the ministry in terms of integrating this information, especially open birthdays, which are very cost-effective, user-friendly, and quite easy to actually scale up, and could actually result in a big reduction of disrespect and abuse.
Great, thanks, David, for that information. We have one more question, time for one more question from a participant. What barriers to respectful maternal care did you find when training healthcare providers on respectful care? Were they receptive to changing their practices, especially with allowing mothers to choose their physician of choice during delivery? So, Rose, can you tackle that one?
Sure. So I think that where we work, there are certainly challenges in sort of changing the culture in the hospital around some of these practices, particularly because there have been sort of historically entrenched practices for how women deliver that have been sort of passed down through medical hierarchy for decades. So I think that it's certainly, in some ways it's a challenge, and I would actually refer to you all in terms of the poll that we did at the beginning of the webinar, that most of you felt that systems barriers were really essentially one of the main impediments for actually delivering respectful maternity care. And I think that that certainly resounds with our experience in Mexico, in that a lot of these facilities are overworked, health staff are underpaid, there's a lot of burnout in these rural hospitals where there's high volume and limited supplies to take care of women in the way that people want to. And so I think that there are a lot of systems-level stressors that can impede respectful sort of practices on a day-to-day basis, particularly with the question regarding birth position. It is something that we're working on, and really it involves one-on-one engagement with the physicians at the facility to encourage them to allow women to have freedom to choose how they deliver. I think a lot of physicians have trained, in a traditional medical sort of setting where women are often in the supine position on their back when they deliver, and it's sort of it's a cultural sort of change to allow women to walk around and to perhaps even deliver standing or kneeling or squatting. And so it just is something that we need to address with the physicians with regards to their comfort level in attending those types of deliveries. It's just an ongoing conversation, and again, we're working with obstetric midwives and nurse midwives and obstetric nurses who are very comfortable with those position changes, but some of the more traditionally trained physicians are less comfortable, so it's an ongoing engagement and sort of conversation around that to advocate for women.
Well, thank you all so very much for the wonderful questions and responses from the field and from the learnings that have taken place. We want to note that for any questions we did not get to, and there were actually great responses from the participants on the webinar today, so thank you for the engagement. If we did not get to your question, we will actually be posting responses on our online portal, and of course the slides and all the recording of this webinar will be available for free for download. So just in summary, thinking about the key lessons that we've learned today. First, we learned about the definitions of respectful maternity care and the frameworks behind it, and also focused on the notable drivers of disrespect and abuse during facility-based childbirth. And of course, these contributing factors vary across settings, as well as including the system-level challenges that are present. And many of the questions actually focus on those system-level challenges that we'll be responding to. Second, we think it's important to note that implementing respectful maternity care practices requires recognizing individual needs and desires of women and what their choices are around the time of labor and delivery. The WHO Safe Childbirth Checklist can be adapted to include the principles of respectful maternity care as part of a larger QI improvement and focus on maternal and perinatal care. And we've heard about a series of programs that have successfully integrated respectful maternity care into quality improvement initiatives, also establishing the metrics and indicators around respectful maternity care, as well as the program tools such as the adaptation of the checklist, as well as birthday approaches that were used in Tanzania. So we'd like to be able to share with you the locations of different resources that are available. From the Ariadne Labs website, we have the checklist and Safe Childbirth Checklist and implementation guides that are readily available, as well as the tools that are used in the other programs here at Ariadne focused on safe surgery, as well as the serious illness care program. Further, we'd like to share the tools available from the Women in Health Initiative and the Maternal Health Task Force resources that focus on that knowledge management database and sharing and being able to give information about maternal health resources. Finally, for our next webinar series on quality of care, we'll be coming ahead in the coming months, and we'll make sure to advertise that through our social media networks. We'll make sure to have more information along with these resources from this webinar will be sent to you via email. And of course, as I mentioned previously, will be available for download through the portal. And we've placed an email address here to respond to any other follow-up questions that you may have about today's topic, as well as other maternal and newborn health programs. So thank you again to all of our presenters and all the participants. We are grateful for your time and energy. Thank you.